Good afternoon, everyone. We'll just give it a 1 minute as folks are logging into the webinar. Welcome. All right. So hello, everyone. My name is Aaron Noel, and I am the Communications Specialist for the California Maternal Quality Care Collaborative. I'm excited to welcome you all to today's webinar that is part of our low-dose aspirin campaign webinar series. In this session, we are focusing on how community engagement enhances clinical care, promoting LDA awareness. Next slide, please. All right, thank you. There we go. I'm just going to present or introduce today's speaker. We have Dr. Lindsay du Plessis, Community Engagement Lead at CMQCC, and Dr. Sarah Vaillancourt, Outpatient QI Clinical Lead at CMQCC. Next slide. We are going to be going over some brief housekeeping rules. So all attendees are muted upon entry. This will help minimize any background noise and ensure that our speakers can be heard clearly. This session is being recorded, so you'll get this recording on demand after within like 48 hours. Slides will be included as well. Please use the Q&A function, and we will do our best to answer your questions during the session. And as always, your feedback is important to us, and any recommendations you might have will help inform us on how we can improve future webinars. Next slide. We have our inclusive language notice here up on the screen. CMQCC currently recognizes identifiers such as birthing people, mother, maternal, they, them, she, her, and pregnancy-capable person are used in reference to a person who is pregnant or has given birth. Next slide. Attendees will be eligible for contact hours. You must be in attendance on the live webinar for a minimum of 50 minutes. And we ask that you please complete the survey, which will be available to you right after this webinar. So without further ado, I will now pass it over to Dr. Vaillancourt.
Thanks, Aaron Noel. Just to start, Lindsay and I don't have any financial disclosures, and what we talk about today is from our own kind of expertise and not necessarily the guidelines, the only way to do what we'll be talking about today. A little bit about CMQCC, California Maternal Quality Care Collaborative. Our mission is to end preventable morbidity, mortality, and racial disparities in maternity care, and we do that by doing a lot of community outreach, quality improvement efforts, including our low-dose aspirin campaign, which we will be talking about today. And we do work in conjunction with the March of Dimes for our low-dose aspirin work. We have some objectives today. Really, what we'll be kind of focusing on today is how we're making the connections between our clinical care and our community outreach, and why that's important from a clinical perspective. We know that in terms of supporting our patients, we need to do more than just what is in the clinic itself, and so we need to make sure that we're making those connections. So we'll talk about that kind of overarching, how those connections are made, and talk about how that's related to maternity care outcomes. We will talk about how we leverage clinic and community partnerships, and then we'll get into our low-dose aspirin campaign, universal preeclampsia risk factor screening, and then how we can do some community engagement to increase our LDA uptake. So just to kind of start, a little bit of background on my clinical experience. I have worked outpatient as a women's health nurse practitioner, providing obstetric and outpatient maternity care to patients during the prenatal and postpartum period. And most of my experience is in the community health environment. So the majority of the patients that I've worked with have had significant social needs. And really why I love talking about this topic is because not only is addressing social determinants of health and evidence-based intervention, it really did change my clinical practice when I started to integrate this into the way I deliver clinical care, and really to help prioritize patient needs outside of just what we think of as medical. So I want to kind of make the case for why we should be doing this, right? To kind of get clinical teams on board with integrating this type of care into our work, and then talk a little bit about the how. So to start, there's kind of this question of what do we mean by social health? So when we think about social health, really it's anything that's happening outside of the clinical environment. When you are going for an appointment, right, you might spend 15 minutes with a provider in the clinic. Maybe you end up going to deliver your baby and you're spending a handful of days inpatient. The majority of our lives are happening outside of those clinical environments. So we know that where we live, where we work, who we're connected with, all have an impact on our health. And those things can both be, can be negative. A lot of times we think of social determinants of health kind of in a negative way that it impacts our health, but they can also be positive and really help promote if we can leverage resources available to us. So just to briefly talk about social determinants of health, this is probably something you have heard of. I think it's kind of been in the healthcare lexicon now for quite a while. And we know that there's kind of these big buckets of social determinants of health. So I like this model because it's pretty expansive in the sense that it has, economic stability, which is going to include our employment, our income, the amount of financial resources we have available to us. Neighborhood and physical environment. So our housing, the stability of our housing, our ability to walk around in our neighborhood, transportation, things of that nature. Education, which is the education available to us, as well as things like literacy and primary language, whether or not we're able to kind of participate in the world around us based on our language capacity. Food, we have food security and healthy access to options. It's notable that these things are separate, right? So do we have access to food regularly? And then do we have access to healthy food? We have community safety and social context. We know that the social support systems in our life, whether that be family, friends, more formal groups that we're a part of, impact our health. And then we have healthcare system. And this includes not only the ability to get medical care kind of in the clinic, but what does our health insurance look like? Is care, is it a high quality of care, and is it linguistically and culturally appropriate? And then you can see the kind of gray band across the top here that also includes racism and discrimination. This model is important because it really recognizes that racism and discrimination, although it's kind of a separate social determinants of health and that it can increase our chronic stress related to exposure to racism, it also touches each one of these categories. And so it's something we need to kind of keep in the front of our mind as we think about these different health factors. And then all of these things kind of work together to result in our individual health and well-being. So that can include morbidity and mortality. It also includes things like quality of life, right? So how is our day-to-day life related to our health status? Before we really dive in deep, I do like to just kind of take a moment and think about how these types of factors impact our own health, because it helps us then relate to the factors that impact other people's well-being. So take a moment just to consider your own social determinants of health. Think about how do they impact your health and well-being. So which ones are negatively impacting you, which ones maybe bolster your health, social connection, things like that. And then we can take a step away from ourselves and think about a loved one. So who in your life, maybe is needing certain types of care, and what health, social determinants of health factors are impacting their health. So, not just kind of the world that they're living in, but also the ability to get care depending on what those health factors look like. And then we can take these experiences with us to extend empathy and compassion to patients that we've worked with, to really consider how social determinants of health are going to impact their health as well, and how we as clinical teams can improve or work with patients to improve those factors. So I really want to take a moment in this webinar to kind of make the case for why we should integrate social health screening into clinical practice. I think a lot of times we kind of think of this as like separate, it's not related to medical care. Someone else on the team will do this, and maybe someone is, and that's great that it's already integrated into the system. But there's multiple reasons why it's important that we integrate this care into our clinical practice. And first and foremost is from a population health perspective. So when we think about health outcomes overall, but specifically maternal health outcomes, we know that there are persisting health disparities, even in outcomes that are overall improving, which California has had some improvement in maternal morbidity and mortality outcomes, but there are certain disparities that are persisting. So ultimately, we will never probably improve those disparities without addressing the social health and social needs related to the context of these disparities. So we start first and foremost with looking at race and ethnicity related to pregnancy-related mortality. You've probably seen these numbers. It's important to reiterate because it is persisting and it hasn't improved. We can see that the Black population has a significantly higher rate of pregnancy-related mortality compared to their white counterparts. And it's important to note that this is not related to anything biological or genetic, but is instead due to the exposure to racism over a lifetime, right? So the exposure to institutional racism can cause chronic stress, which we know is resulting in these disparities. So if we're not addressing kind of the racism and the associated access to resource issues that we have from that, we're only going to continue to have these disparity issues. We also can see that, there's differences in pregnancy-related mortality based on where we're born and where we live in California. So those born in the United States actually have a higher pregnancy-related mortality compared to those born outside of the United States. And there's multiple reasons for that, but this does play out in the research that being born or living in the United States longer results in more negative maternal health outcomes. And then you can just see regionally that in California, there are different maternal mortality rates based on region. So we can kind of think of that related to maybe access to health outcomes, certainly environmental health outcomes. Right now in Northern California, there's kind of a lot of wildfires going on that's going to impact people's health and ability to get care. So there's regional differences in these outcomes as well. And then you can see that there's a really large difference in pregnancy-related mortality between Medi-Cal covered patients and private insurance patients. This is likely for a few different reasons. One, Medi-Cal patients are usually getting, types of care that tend to be more publicly funded, which can change the ability to get, have easy access to care. But we also know that Medi-Cal can be kind of a proxy for financial hardship. So most folks who are on Medi-Cal are going to live closer to the poverty line than those who have private insurance. And so we can see that if Medi-Cal is kind of a proxy for financial hardship, and that's income is a really big factor related to pregnancy-related mortality. And then the last one here is education level. So we just see that there's a significantly higher pregnancy-related mortality for those who have less education than those who have more. And so when we're kind of thinking about populations and considering population health interventions, we really need to consider kind of these disparities and how the social health impacts may need to be considered to reduce disparities overall. It does also matter in terms of individual patient outcomes. So we know that social health has a direct impact on our medical outcomes, or what we tend to think as more medical rather than social. It's kind of an easy way to think about this is that we know that social determinants of health have an impact on health behaviors or access to healthy behaviors, right? So think of nutrition, right? If we have limited food security or access to healthy food, exercise, sleep, and stress management, those things can be related to support system, our employment and what that looks like. But I think it's also important to recognize that a lot of kind of the negative impacts of certain social determinants of health, like low income, results in chronic stress. So we know that lower financial status, so living in poverty, as well as things like racism, can increase our chronic stress over time. What that does is it results in someone kind of having a stress response for an extended period of time. That can result in increased rates of cortisol in the body, adrenaline in the body. And so our body's actually functioning differently when we are in a period of chronic stress. And what that results in a lot of times is an increased risk for hypertension, heart disease, diabetes. We also see higher rates of depression and anxiety associated with this kind of chronic stress state. Specifically in pregnancy, we know that a chronic stress state does increase our risk for hypertensive disorders in pregnancy, which is related to preeclampsia. There is some evidence as well that it is associated with higher rates of preterm birth, although that's a little bit kind of to be determined, but it's good to kind of consider that one of the things we might want to do as a clinical team is really consider this kind of chronic stress related to social health. It is also important to note, though, that we do have positive social determinants of health that can be health promoting and can be protective or increase our resilience. So everybody's going to be different, right? If we have a good social support system, we have people we can rely on, then sometimes that can act as a mediating factor and actually reduce the chronic stress load on the body and promote health. And then my last kind of big why argument for why we should pay attention to social health as a clinical team members is related to patient experience and engagement in care. Basically, when we are asking folks about their social life, their social status outside of the clinic, it allows us to really provide whole person care. So we're not just looking at a diagnosis list or a problem list or their lab results or their blood pressure measure. We're asking, what does your life look like outside of the clinic, so we can understand more fully patient needs and patient, where a patient might be thriving. And this is particularly important in maternal care settings because we know that the rates of individuals feeling like they're being dismissed by their care team, they're not being listened to, or they don't feel comfortable bringing up concerns is quite high. And so if we're able to create an environment where we're invested in patients outside of their medical needs, we're asking what they need from us and really creating a healthy patient-provider relationship, it should improve these outcomes over time, at least within our own clinical environment. And I will say, from a provider perspective, this is what I saw as a clinician. So we were able to really connect over, just relate as people, increase the trust with patients. My medical assistants also tended to say that they found that they were able to forge deeper connections with the patients related to the social health screening. And so this was something that, in terms of immediate impact and how we were able to relate to patients, it was very successful. So hopefully you found one or two reasons in here as to why we should be paying attention to social health and clinical care. But I do want to give you a few kind of answers into how we can implement this into clinical practice. So the way that I tend to think about social health screening in clinical care is that we're going to have screening first, followed by intervention. And I say this till I'm blue in the face. So the purpose of screening is not screening itself. Really, the purpose of screening is intervention, right? We're not just screening to check a box to say that we've screened someone. We really want to use screening in order to get patients the specific type of care that they need. And you can think of this from a health equity perspective, because whereas equality is delivering the same type of care to every patient, equity is really identifying specific patient needs and getting patients the specific resources that will help them. And so for screening, we're really figuring out, well, what does the patient need, right? Can we identify patient needs? And intervention is providing patients with appropriate resources. Now, I think the intervention piece can be the scary part regarding clinical implementation, because it can be overwhelming, right? If someone has 5 different social needs, like, I'm not going to provide counseling, I'm not going to provide a lot of case management, I'm not going to work with them on their employment options or their housing. Really, what this often looks like from a clinical perspective is just being able to find the patient an appropriate referral to services that can fill whatever gap that you're trying to fill. So from a screening perspective, really the way that we want to do this is as efficient as possible, right? I understand that we have a lot of other tasks on the plate that we can't always split time between other things. And so we want to find a tool as efficient as possible. And really, to do that, we need to generally stray away from big, long social determinants of health assessments. Ultimately, as a clinician, as a provider, a nurse, a medical assistant, I'm not looking for every single piece of information related to someone's social determinants of health. I'm just looking for areas that a patient might need additional support. And so we don't have to kind of get lots and lots of information related to their social life. Now, there's always a question of delivery method. So do we do this as a questionnaire through the EHR? Do we do a, just a patient completed handout questionnaire? Sometimes when I don't have access to this type of questionnaire, I will just ask a few questions, right? Tell me about your housing situation. Tell me more about your employment situation. Are you having any financial hardships? Do you need assistance with transportation, right? Just a few questions can actually give us some insight into whether a patient is feeling very stable and good in those kind of social determinants of health, or if they're needing additional support. And then I do like to note here, and this is kind of if you're doing something more standard, it is important to standardize documentation, just so that way you can track with the patient over time. There is ICD-10 coding options for just screening. So saying we screen for social determinants of health today, and you can put it in your ICD-10 codes. And there are specific ICD-10 codes related to different types of social determinants of health. So you can think like housing instability, employment issues, and you can code those. And the reason that that's important is obviously data can be important related to these outcomes, but also to help clinicians track over time, are there things we need to continue to check in about. These are just some examples of kind of short, efficient social determinants of health screeners as opposed to a full assessment, because we're just looking here to find out, are we having issues? Are there areas that a patient needs additional resources for? So when I tend to think of social determinants of health screening and intervention, I think of it through this type of workflow, right? This is very generalized, but this is what it tends to look like. So you start with the social determinants of health screening, and you're kind of have already figured out who's screening the patient, how often is the patient screening, and how is that going to be done. And maybe that screening results in having no risk identified, in which case, great. You can say we've asked the patient, they're great right now. We don't need to provide them any additional resources, and then you can document and rescreen as appropriate. Why I think this is also useful for those who might not have immediate social determinants of health needs is because it kind of opens the door and allows for a patient to come back and say, remember last time we did that screening, I actually do have some issues now that I'm here again. So it does kind of still, imply to the patient that we are interested and care about things outside of direct medical needs. Now, say you do a social health screening and a risk is identified, right? So we've done the screening, we flagged a risk. Next, we want to think about that referral, right? We're going to refer to additional services in order to address whatever need the patient has. The way to think about this, I think, is in two big buckets. So we have internal referrals and external referrals. It can be a great place to start to determine, what do your internal referral options look like? Do you have behavioral health? Do you have case management or someone who helps with insurance, Medi-Cal enrollment? What do you have internally that you can refer to? Because those tend to be an easier way to do referrals. And then once you have a sense system, we can start building out external referrals to community-based organizations or government programs that might help kind of fill in the gaps outside of what we have internally available to the patient. And again, it's important to kind of standardize the documentation on this because we're going to want to follow up with the patient. So we say, oh, we referred you to this service. Were you able to get some assistance? Or, last time you were having some employment troubles, how are things going now, right? We can check in with the patient, really make sure that we're working to improve some of these issues that we've identified through our social health screening. Now, the intervention component, I think one of the best ways to approach this is really to create a resource guide. And this can be formally or informally. So you could, do it for your office, you could do it for your organization, and because it will look unique to each community, right? What resources are available in the community for patients to access are going to be different. Now, I will say from experience of kind of doing this work in a clinical environment, this does tend to be the piece that has the most kind of time burden on the front end, right? It takes some time to find out what resources exist, maybe make connections with those resources. But I do like to advocate for this because once you have the resources available to you, then when you have a patient who has employment issues, transportation troubles, insurance problems, you already have the resources available to easily and quickly do those referrals. So even though it takes a little bit of time on the front end, it should streamline your referral process on the back end. So there are some resources on the screen here. So One Degree and Find Help are both websites that you can visit, and you type in your zip code and it will pull up community-based organizations that provide services for most of these social determinants of health. Another thing I recommend is really getting in touch with your public health department, because public health departments do a lot of really great work and we tend not to be very directly connected with them as clinical folks. Some examples from a maternity perspective are going to be your Black infant health programs, home visiting programs. A lot of times they'll have maybe some support groups and things of that nature. And direct connections to these services can be effective in making sure that patients actually get the services that they need. We can certainly find a resource and hand someone a phone number, but there's still some significant barriers to that. So if we're able to talk to public health, to talk to some of the community-based organizations we're interested in working with, we can streamline that referral process to reduce as many barriers for the patient to get to the services that they need as possible. And then related to sustainability, if this was something you really wanted to take on, is to think about how we can integrate this kind of resource guide into a referral system. So it's easy to use, accessible, and has that kind of streamlined approach to maintain the use of it in a clinical environment. So luckily, lots and lots of organizations have done work on social determinants of health screening and intervention. And so I've linked here a bunch of toolkits. I don't have all of these here to be overwhelming, just to recognize that each organization is going to have different needs, going to have a different community that they're trying to serve. And so looking through these to kind of pull what might work for you, I think is a really good place to start. And these are very implementation focused and not kind of bogged down in the weeds. So there's a lot of great tools in here if you're interested in doing some of this implementation work. So how does this connect to low-dose aspirin in pregnancy? I think that's a good question. You're like, we came to a low-dose aspirin webinar. It relates because of a few different things. So one, we're going to talk about preeclampsia risk factor screening. If you look through the risk factor screening, you will have noticed that some of the risk factors are social in nature. And so what do we do with those when we think about social health and clinical care? And the other component is that when we're talking about increasing low-dose aspirin in pregnancy, there are things that impact adherence related to whether or not a patient actually stays on the medication throughout the duration of the pregnancy. So we'll get into that a little bit. First, just to go over the recommendations. So low-dose aspirin is recommended by all of the major guideline bodies, so ACOG, USPSTF, and Society of Maternal Fetal Medicine. And it's recommended because we know that starting a low-dose aspirin at the appropriate time for patients who are at risk of preeclampsia significantly reduces the risk of preeclampsia and associated preterm birth, right? So we have this, cost-effective, relatively easy to take medication that we know reduces the risk of preeclampsia and preterm birth. So it's something that is a really exciting intervention because it's relatively straightforward to do. So the recommendations are to start between 12 and 28 weeks, ideally sometime between 12 and 16 weeks for those at risk of preeclampsia. The recommendation is to continue until delivery. Recommendation on dose is a little bit mixed, but it is appropriate to do 1 baby aspirin, which is 81 milligrams, up to 2 baby aspirin, which is 162 milligrams. And then who is at risk for preeclampsia? It's going to be anybody who screens for 1 or more high risk factors on that preeclampsia risk factor screening, or 2 or more moderate risk factors. And so really kind of the cornerstone of increasing low-dose aspirin does tend to be this kind of early universal preeclampsia risk factor screening. So we should really be screening every patient who comes in the door for preeclampsia risk, because even though some of the risk factors seem obvious. Some of them are less so, like social factors, like demographics. And we should do this as early as possible to provide us time to be able to talk to patients about the low-dose aspirin recommendations, why it's necessary, answer questions, all that sort of thing. And then really, everyone who is coming into contact with pregnant patients needs to be aware of this. Maybe you're not the initial prescribing provider, but being able to make sure that a patient is taking low-dose aspirin halfway through their pregnancy, that they don't have additional questions, that they're not at risk of discontinuing, is important in terms of reducing those risks of preeclampsia and preterm birth. So we kind of talked about this already, right? We kind of are going to talk about the preeclampsia risk factors related to social health, and then social health related to LDA adherence. So this list, this long list, is from the USPSTF, and these are the risk factors for preeclampsia. So what's nice about a universal risk factor screening is that you don't have to memorize these, right? If we are screening everybody, we're making sure in a tool that, we're screening for the appropriate things. But I want to specifically draw your attention to the 2 moderate risk factors that I have flagged here. The first one is Black persons, so due to social rather than biological factors, and then lower income. So these are 2 separate risk factors. Someone might have one and not the other. Some might have both. But it's important to note that you can see at the bottom, also flagged here, it says these factors are associated with increased risk due to environmental, social, and historical inequities, shaping health exposures, access to healthcare, and the unequal distribution of resources, not biological propensities. So we kind of talked about this a little bit previously, but we know that Black persons have a risk factor for preeclampsia and overall chronic stress, right? Because of that exposure to systemic racism. So this is not something that is genetic, it's not biological, it has nothing to do with an individual person or their, kind of situation. It's their exposure to racism over time that is important to recognize. And this is evidence-based. We know this is true. It has been established in the literature. And so it's important that when we're screening for this, we kind of keep in mind why Black race is an important factor to screen for and intervene related to. So basically, I kind of want to make the argument here that yes, if someone has the risk factors, including Black race, to start on low-dose aspirin, we should get them on low-dose aspirin, but the intervention does not stop there. So it's important when someone is screening for positive for preeclampsia risk with one of them, including Black race, that we have a conversation with them about this context, right? It is not biological, it is not genetic, it is not individual, it's rather the impact of systemic racism over a lifetime related to chronic stress. So we need to be able to have these conversations with patients respectfully and in a culturally competent way. But we also need to be able to take the further step, right? So we know that Black race can also be a risk factor for other maternal health outcomes that we can intervene on. So making sure that patients have access to appropriate services. This is going to be the opportunity where you can look into your community, find community-based organizations that support Black birthing people. Specifically, the Black Infant Health Program through public health is a really great place to start. There are many community-based organizations depending on where you live. Another thing I do tend to spend some time talking to my patients about is doula support and why the evidence shows that doula support, particularly inpatient, can improve outcomes, right? It improves a patient's ability to advocate for themselves, for their voices to be heard, for concerns to be addressed, and really taking these things seriously because it does impact individual patients. In that same vein, but with a different risk factor, is low income. So low income is a risk factor for preeclampsia. If someone has low income and maybe one additional moderate risk factor, we should get them on low-dose aspirin. That is not actually, though, addressing financial hardship or low income. So we want to be able to take the additional step to connect patients to resources they might need. I want to just point out that most of the social determinants of health that we've talked about today are actually very impacted by finances, wealth status, poverty level, right? employment and direct available finances, where we live, our neighborhood, our access to education, our food security, our neighborhood safety, and our access to quality healthcare are all impacted by our finances. And if you think back to the disparities that we looked at, the difference between maternal mortality related to Medi-Cal patients versus private insured patients, it's a significant difference. And so again, when we're doing this risk factor screening, we want to be able to talk to patients respectfully about why low income is a risk factor for preeclampsia related to the chronic stress that comes from living in poverty. And then also to be able to connect patients to appropriate referrals to address their financial hardship, because that hopefully is going to reduce our chronic stress level over time to promote healthy outcomes. And it also tends to act as a way to be proactive to make sure that a patient has the time, has the transportation, has the knowledge to navigate the health system to get the necessary care that they are kind of signed up to do. And then separate from risk factor screening is this kind of patient uptake and adherence, right? So we know that there are social factors that impact an individual's likelihood of starting and continuing a medication. And in pregnancy, this is particularly true because we often hear that, patients are nervous to take medication when they're pregnant. Is this going to hurt the baby? Is this safe in my pregnancy? And there's a few different factors that impact this. So first I have here literacy and language, right? Does the patient understand what you're recommending? And so this could be from a health literacy perspective, maybe not understanding kind of the reasons behind the medication recommendation. It could also come from a language perspective, right? If a patient is needing interpreter services because they are not understanding medical recommendations in English, things of that nature. So what do we do about this? We make sure that our education is culturally and linguistically appropriate. Sometimes it can be useful to do health literacy screenings and just making sure you have interpreter services for patients when they need it. The second one here is just means to obtain medication. So think of, again, transportation cost. We tend to think of low-dose aspirin as low cost, but some patients may not be able to afford it. And then I have knowledge of navigating the pharmacy system. So this is something that ended up being very much part of my practice, is that individuals who were new either to the state or to the country would just not really know how to go and get their medication. They didn't know about bringing their insurance or where to go or how to talk to the pharmacist. And so what we could do was be proactive here, provide them that education, which is going to reduce barriers to that initial start of the low-dose aspirin. And then lastly is community support. So we know that how a community around a patient perceives a recommendation impacts whether or not the patient is going to kind of take up what the recommendation is. So we want communities to know about low-dose aspirin, to feel comfortable with the pregnant people in their lives taking low-dose aspirin. And so this really has that connection back to community-based organizations. Can we talk to them about the importance of this? So that way patients are getting that reinforcement from their community as well. We're very lucky in terms of doing low-dose aspirin work now, because the March of Dimes is actually doing a very large kind of public service campaign to increase the public awareness of low-dose aspirin, because a lot of folks have never heard of this recommendation or don't know about preeclampsia as a risk. And so really making sure that people outside of the clinical environment understand and recommend, or a patient asks about low-dose aspirin is going to be important. And then my last slide here, this is actually Lindsay's slide, and it always looks great. It really kind of ties everything in. So, this is really kind of an illustration of all the influences on pregnancy, and low-dose aspirin uptake. So, patients very early, they start by coming into medical care. Maybe we recommend low-dose aspirin at that time and send them a prescription. A lot of patients are spending a lot of time on social media. They may hear things that kind of reinforce a low-dose aspirin recommendation or things that make them nervous. Similarly, with a family impact, their health insurance has an impact. We know that community support has an impact. And then really what happens at the pharmacy. We've actually heard some instances of the pharmacy not wanting to fill low-dose aspirin in pregnancy just because of a knowledge barrier related to that. But all of these things are going to impact whether or not a patient takes low-dose aspirin. And so we need to be considering, outside of just that prescription, what it is that we can do to increase LDA uptake, because ultimately we're going to see a reduction in preeclampsia and preterm birth rates. And now I will pass it over to Lindsay to talk a little bit more about kind of connecting the dots, community, and patient education.
Hi, can you all hear me? Okay. Give me 1 second. I'm unable to, hold on, show my video. Let's see if this works. Okay. Hi, everybody. Thanks so much, Sarah. Happy Monday, everybody. Thanks so much for joining today. So I'm just going to talk briefly about the low-dose aspirin campaign that we were doing in partnership with the March of Dimes. So once again, as Sarah mentioned, they are funding our work. So thank you so much to the March of Dimes. Next slide, please. So most of you, I'm sure, have heard of our campaign. If not, thank you so much for being here and welcome. And let's spread the word about this campaign. So for our first cohort, these are the pilot hospitals that we worked with. Loma Linda, Riverside, UC San Diego, Scripps, Mercy San Juan, and the clinics that are associated with them are in the parentheses you see here. And then lastly, Kaiser, Northern California is also doing a low-dose aspirin campaign. And so Sarah and I have actually just finished our recruitment efforts for cohort 2, which will be starting next month. Next slide, please. So here are some of our patient education materials, and they are in English and Spanish, and we are continuing to do more languages, and we continue to identify and fine-tune community messaging and outreach materials to educate women and birthing people about the role of low-dose aspirin during pregnancy. And so here we have our poster and our information sheet. And as you can see here, they both feature a QR code that takes patients back to the March of Dimes website to learn more about the importance of low-dose aspirin. And we really encourage patients and birthing people to talk to their healthcare providers about aspirin, as well as highlighting the importance of keeping your baby safe, as you can see here, which is a priority we know for women and birthing people. We've also done some videos. We really wanted to kind of show the interaction between patient and provider and, include discussions on maternal health disparities and how to best model the conversations. And we've done one of those videos at one of our pilot sites I just mentioned. And this video has been used for educational purposes and grand rounds in the clinic and hospital settings. Also put together a patient advisory committee with women and birthing people from the surrounding areas of those pilot hospitals and those clinics. And we meet with them once a month. And they truly, truly have been a wonderful group. And the times that we meet once a month is really a safe space for these folks to kind of talk to each other and share information. And they have met with these pilot hospitals really to collaborate and enhance the importance of patient and community voices. And right now we have about 11 folks that are serving on that committee. And what's really important to note is that they had their eyes and their input on these patient education materials because we really wanted something that resonated with patients and the communities. And we will put together another patient advisory committee with this second cohort. We also had some press releases that each hospital announced. And then community events. We attend community events. We really get out there. We're out at churches, at health fairs, to really spread the word about this campaign and educate as much as we can. Next slide, please. So this is another example of patient education materials with the prior information in a patient-centered format that we've been providing to our pilot systems, hospital systems, on behalf of the March of Dimes, along with that information sheet and the poster that you just saw. So we created this one specific to the campaign, which the patient advisory committee weighed in on as well. And so the original preeclampsia risk screening tool was created in collaboration between the United States Preventive Services Task Force, the American College of Obstetricians and Gynecologists, and then the Society for Maternal Fetal Medicine. And so some hospitals have even built this into their EPIC. So the tool released by the task force can be a bit confusing, which is why we worked with the Patient Advisory Committee to create the Should I Do aspirin questions, which were written by and for patients. And you can find all of these patient education materials on our website at cmqcc.org, along with some patient short stories that we share on there as well. Next slide, Sarah. So as you see here, it's really important to start these discussions early on in pregnancy, because it might take an appointment or two for folks to really get the information that they need to be able to digest it all and to get their questions answered, which Sarah mentioned earlier. So it really is our responsibility to have these compassionate discussions with patients. And so we want to make sure these patients are feeling empowered, that they're feeling well informed about this information and equipped to make their own, the best decisions for themselves and for their baby. We really want to explain the risk factor screening process, the benefits, which can help identify those who are at higher risk for developing preeclampsia, and really be able to provide opportunity for prevention. And then lastly, review and discuss all of the risk factors with all of the patients. Explain each of these risk factors fully, give some time to talk about it, and make sure that the questions are being understood by the patients, right? And make sure that they can verbalize what is being explained to them. Next slide, please. So this is one of my favorite slides. I am a public health person and I love conceptual models. And so this is a community-centered approach to promoting low-dose aspirin adherence using a methodological approach to center and engage community. So I want to be clear that this does not include all populations and interventions within the scope of this project. This is just the approach that we are taking. So you can see the different folks that are under population. We have providers, communities, pharmacists, nurses, doulas, midwives, birth workers. So important to include all of those people in these types of interventions. And we want to educate, which we mentioned, we have those patient education materials. We have videos. We want to use social media because everybody is on social media. We have outreach. We get out there into the community and those health fairs and speaking at conferences. And then lastly, data, really, really important, hospital data, clinic data, and provider and patient surveys as well. And this will all lead to establishing guidelines for a community-centered promotion of LDA. Next slide, please. So just some closing statements. Next slide, please. The work continues. We finished with our first cohort. However, we are still meeting with them. We want to make sure sustainability is still happening. So the work continues, right? And it will continue with our next cohort that we are starting. Community engagement is just so important. We want to engage with communities to collaborate. Clinic to clinic and community to community networks are vital. We want to connect inpatient and outpatient teams, and we want to connect clinical teams with community teams. And we know that, clinic and community partnerships really are crucial in addressing and preventing maternal and infant mortality. There's enhanced access to care. Clinics can partner with community-based organizations to provide education on prenatal care, birthing options, even postpartum support. And transportation, I think Sarah mentioned that earlier, community partnerships can help address different barriers to accessing care, such as transportation challenges, and local organizations can help arrange transportation or navigate the healthcare system. Culturally competent care, I talk about often, tailored interventions. Community organizations often have a really deep understanding of the cultural and socioeconomic factors that are affecting families. Women and birthing people spend most of their time in the communities, not at the hospital. And so they can work with clinics to develop culturally sensitive care plans and communication strategies. Building trust, also important. Clinics that partner with community organizations can build this trust within the community, which is crucial for encouraging individuals to seek and to adhere to care. Cultural competency training, maybe offer training to clinic staff and community birth workers on cultural competency to improve understanding and collaboration. Integrated support services, partnerships, these clinic and community partnerships can facilitate access to a range of services beyond just medical care, including mental health support and different social services. And addressing these bigger needs can improve overall maternal and infant health outcomes. And then leveraging data and research. We really want to encourage and support collaboration between clinics and community organizations to identify gaps, evaluate interventions, and develop evidence-based practices. And then policy change as well. Community organizations can advocate for policies and programs that address systemic issues that are contributing to these high mortality rates. And clinics and organizations can really work together to influence policy changes that support better maternal and infant health. And then lastly, just the community engagement and support. You know, community organizations can really help to facilitate support groups and peer mentoring for pregnant and postpartum women, providing emotional and practical support. And clinics and community groups can work together on educational initiatives like this one to raise awareness about maternal health issues and promote preventive care and adherence. Next slide. So what can you do? Learn more yourself and listen to these patients and birthing people. Educate your patients, educate family, educate friends about low-dose aspirin and about preeclampsia symptoms. And some key messages you can share with your patients when they ask about low-dose aspirin is, hey, you know, low-dose aspirin is safe to take. It's safely used in all races and ages. Low-dose aspirin can make pregnancies last longer and keep both moms and babies safe. And then lastly, if taking LDA, it is important to take it daily. Next slide. So our overall mission at CMQCC, as Sarah mentioned earlier, is to end preventable morbidity, mortality, and racial disparities in maternity care. And we create tools, including scripts and education materials, and improve outcomes through data-driven quality improvement. And so just to hone in on this last sentence, we really must listen with our hearts and minds and remember that the more different someone is from us, the harder we need to listen. Next slide. So here are our different social media channels. Please follow us on LinkedIn, Facebook, Instagram. We promote our webinars there and our resources and our patient education materials. Yeah, I think that's it. Thank you so much. So we have a couple minutes for some questions.
Let's see, I saw the chat going. Some Q&A, let's see. Okay. All right, so I'm going to go ahead and read through some of these and we'll answer them. So first question is a really good question. It says, from anonymous attendee, thank you for your question. It says, I believe a majority of patients we see stop aspirin around 32 to 35 weeks. I thought aspirin until delivery can increase postpartum hemorrhage. Can you touch on this a little? That is a great question. That was previously a very big concern regarding safety, but the evidence shows that there's no difference in postpartum hemorrhage rates between those who continue low-dose aspirin through delivery and those who stop early. And so in terms of kind of simplicity of just having a patient continue through the duration of the pregnancy, that is the recommendation from USPSTF, ACOG, and the Society of Maternal Fetal Medicine. All right. So question is, what do you see as the role of doulas and community health workers in supporting screening for risk factors and or uptake and adherence to LDA?
I think this is a great question.
That's a good one.
I've often heard that doulas and community health workers are a safe space for these patients and birthing people, and they're familiar with the communities that these patients are coming from. And thank you for bringing this up, because what we are going to do, we have this webinar series, and we will have one focusing on the importance of doulas and community health workers. So if you are interested, please reach out. Please keep checking our website. But they are truly, truly important. They understand the patient, they understand their needs, and they can help kind of relay that information to clinics and hospitals. And they can also help the patient advocate for her health and well-being.
Thanks, Lindsay. So the next question is, what are the side effects? Oh, sorry, I skipped one. Do you do specific work to help doctors better communicate the risk to patients, especially BIPOC communities? Everyone's there, Lindsay? I can jump in.
We are doing that, yes. So, you know, we're trying to touch everybody, right? We even had a webinar on pharmacists and the role that pharmacists play in this work as well. So we had a webinar back in December, which was discussing risk respectfully. So if you didn't get a chance, please check that webinar out, and that can actually help answer your question. You know, we talked about being culturally specific, being culturally tailored, culturally competent, really to have that training and understand that training. So we will continue to do this work. This is very, very very, very important in this initiative to do this. So thank you so much for mentioning that.
Yeah, and just to kind of build off of that, I think, you know, as clinical teams, if you're not kind of there yet in terms of doing some specific communication work, really taking the approach of being, you know, culturally humble, right? We don't know where people are coming from or what their specific perspectives are. So being open-minded, inquiring about that, really listening to patients' questions is going to be important. Okay, so next question. What are the side effects to expect when taking low-dose aspirin in pregnancy? Any contraindications like placenta previa? Also a great question. So in terms of side effects, there's not like a long reported list of side effects. What I do always say to patients is if you're experiencing it and you tell me it, it doesn't mean it's impossible, but there's not necessarily things that, you know, kind of counsel on regarding side effects. In terms of contraindications, actually bleeding in pregnancy is not a contraindication. It can be a caution. So if someone is, you know, if a provider is hesitant to start low-dose aspirin because of bleeding in pregnancy, that's totally reasonable. But contraindications include things like stomach ulcers or things like of that nature, any anaphylaxis to, you know, NSAIDs or aspirin in the past. And then the other like strict contraindication is nasal polyps. So ones that bleed. If you are wanting to get like deep into this, look at the USPSTF recommendations because it is listed in there if you want like the full list. Okay, so it says, hello, nurse home visitor here. Just wondering when the client is advised to discontinue or continue LDA after birth. I have had 2 clients that didn't know if they should continue until their postpartum appointment or just to delivery. What are clients being recommended to do? Great question. I think there's a couple pieces in that. So the recommendation is to stop at the time of delivery. So they don't need to continue postpartum. But I think you've really touched on how we can't just send an LDA prescription and then provide no counseling. So really making sure that the recommendations are clear to patients, that they understand the recommendations, and we provide time for questions is important. Next question, do you have resource recommendations for other preventable measures such as diet and exercise? Also a great question. Couple things to look at. I don't think we have, let's see, the big one that comes to mind is that Million Hearts campaign just came out with a hypertensive disorders of pregnancy change packet that has a lot of resources in there regarding implementation. So I don't know if, Lindsay, do you know if CMQCC has anything specific internally?
I don't know.
I don't think so, but I would recommend looking up that, and we can maybe, I can write it in the chat what that is. The Million Hearts Hypertensive Disorders of Pregnancy Change Packet. All right, so next question. Lots of good questions, love that. I know you mentioned some barriers arise after prescribing LDA, such as the reluctance of pharmacists. So I'm curious to know what interventions have been implemented to curb some of these barriers. That's a really good question. Lindsay, do you want to take that? Do you want me to?
Well, I'll just say one thing in particular. There was a large health system who had a plaque in a pharmacy, and it said, aspirin causes birth defects and cancer and things like that. So of course that's really, really scary. So what we are doing is having conversations with folks to figure these things out. And it had to do with Prop 65, and they were working with their teams to get aspirin off of that plaque. So we really just need to continue to collaborate. We need to just educate as much as we can to be able to get rid of these barriers. But those are some of the steps we are taking with this initiative.
Great. Thank you, Lindsay. Yeah, I think that's a good example of really needing to hit the whole, healthcare system, especially if a patient is going to fill an aspirin prescription at the pharmacy. I think other concerns regarding things like reluctance is, like Lindsay mentioned, like, is this safe for baby? Is this evidence-based? I've never heard of this before. I didn't take it in my last pregnancy, right? For a lot of folks, it feels very new, and that can be scary. So really, from an intervention perspective, just providing people the time to ask questions, the ability to follow up about it if they're still not sure, I think is really important. Okay, so when do we start to use low-dose aspirin in pregnancy? The recommendation is between 12 and 16 weeks ideally, though you can start all the way up to 28 weeks. How is the response from patients? I think for the most part, when patients kind of get the full counseling and understand the importance of the low-dose aspirin, the response is good. But with any medication recommendation, you're going to have patients who decline. And so I think a big piece of respectfully talking to patients is also respecting patients who decline despite knowing all the information. But I think overall, the response has been quite good. Okay, are you answering this question about misinformation?
It's a great question.
Or it's 101. So if you
yes.
All right. So last question. I actually may need to look into this one, but it says, what about patients who have had bariatric surgery when NSAIDs are a relative contraindication? Does the benefit outweigh the risk? That's a great question. And I don't think I know the research off the top of my head. I would suspect that it probably does, because the low-dose aspirin, it is a low dose. The risks are very low. And it's not, bariatric surgery is not a contraindication to the low-dose aspirin, but I may do a little bit of looking into that to kind of give a definitive answer. All right. Well, we really
questions. Yeah. And I know
great questions. We really, really appreciate everybody attending today, and hopefully this kind of gets you thinking. If you do want to reach out to us with any additional questions or resources or anything like that, please don't hesitate. Lindsay, anything else? Great.
I think that's it. Thank you so much for joining.
Have a great rest of your afternoon, everyone.